public session there? Yes. Okay, can I just advise members that David Brooks, Jonathan Buckley and Saoirse Eastwood are joining the meeting remotely. Can I just check that all three of you can both hear and see us? Do you want to stick your thumb up?
Saoirse's note.
Yep.
I can't see David or Jonathan. I can see Saoirse. Saoirse, can you hear and see us?
I'm having some issues with my pack.
They're on mute. Are they? Do we know if the other three are in?
Yep, I can hear you.
Thank you.
They're all here.
Hi, Chair. I can see you all.
Well, we can
I'm not
hear
sure
you.
if you're seeing me.
Yep, we can hear you. And David, can I just check that we can hear you as well?
Yep,
Or see?
yep, I can see you.
Okay.
Hear you.
Thank you. So,
I'm having some issues with my pack here. It's just circling. Is there a Wi-Fi problem today, or what's like?
There was a
Okay,
power
go. I'm
outage.
in.
okay. So we've got the quorum. Can I just inform members, as always, that mobile devices are permitted, provided they are muted and on airplane mode. Tablets and laptops should be used for committee business only during meetings. And welcome everybody to our 5th meeting of the Democratic Scrutiny Committee. We have no apologies. Can I just remind members that you're obliged to declare any relevant financial or other interests, and if anyone has any interest to declare, they should do so at the start of the relevant business. Moving on to item 2, refer members to draft minutes of proceeding, page 4 of the pack, and can I ask that the draft minutes of the meeting on 7th of March are a true reflection of the proceedings? Consent. Okay, matters arising. At last week's meeting, the committee discussed the impact that European Parliament recess dates might have on the work of this committee. I'm going to ask Sinead, the Senior Assistant Clerk, just to give us a rundown on this.
Yeah, so members, the question was raised last week about the impact that European parliamentary recess dates would have on the publication of EU acts in the official journal of the EU. So it's unlikely that European Parliament recess dates will have an impact, as publication of EU acts only happens at the end of the legislative process. So in general, once the European Parliament and Council have reached provisional agreement on a proposal, there's an approximate 8-week process for a verified text to be produced. The text is then formally adopted by the European Parliament in a plenary session. It's then the Parliament and the Council then sign the legislative act, and then it's published within a matter of days in the official journal. So in short, the recess date does not affect the publication of a legislative act once it has been formally signed before the recess starts. So the last plenary, European Parliament plenary, will be the 25th of April, and the Parliament won't sit in May or June because of the European elections, and will sit again in July. So there'll be that 2-month period, yeah.
Okay. People happy enough with that information?
Yep.
Thank you.
Okay. So, next item then of matters arising, as part of the committee's engagement or education programme, the clerk has been in touch with the House of Lords European Affairs Subcommittee on the Windsor Framework. So the chair there and other members of the subcommittee are available for a private introductory meeting on Thursday, 21st of March. It's next Thursday. The meeting will take place in this room via Zoom at 10 a.m. with our committee meeting then starting at 11:45 afterwards. Just can I remind members that the committee is also next week due to host an in-person meeting with the chair and members of the Westminster EU Scrutiny Committee at lunch time next week after our committee. So an agenda and papers for both meetings will issue to members in due course. Steve?
Yeah, just apologies to the chair and the rest of the committee. We've had a family bereavement and I might be in the United States next week, so I mightn't be available for that.
Okay, sorry to hear that, and accept the condolences of ourselves on that, Steve. Okay, moving on then to item 4 on the agenda. So proposals to amend regulation 2017-852 on mercury, and we have a oral briefing from the British Dental Association. So just while the members are coming forward to take their seats, can I refer committee members to the relevant papers at pages 11 to 79 of the meeting pack. And in front of us today we have Tristan Kelso, who's the director of the BDA here in the north, Ros McMullen, who's the chair here in the north of the BDA, and Ciara Gallagher, who's the chair of NI Dental Practice Committee. So, and all three will give evidence to the committee on the proposal to amend the regulation on mercury, which will have the effect of phasing out the use of dental amalgam by 1st of January 2025, except when a dental practitioner considers the use necessary, specific, or due to a specific medical need. So a derogation until 30th of June 2026 has been provided for to help minimise any negative socio-economic impacts, in particular for low-income patients. Can I just remind everybody that the session will be recorded by Hansard. So can I welcome you all to the meeting, and just before I hand over to yourselves, just again remind members that this session is part of evidence gathering exercise in anticipation that the committee will be notified when the EU Act is published in the official journal, and then obviously if notified the committee will need to decide whether it wishes to conduct an inquiry as provided for in the regulations. So members should try and focus their attention on the key questions for us on whether it appears likely that the proposed replacement EU Act would have a significant impact specific to everyday life of communities here in a way that is liable to persist. So thank you again for coming, and I'm just going to hand over to yourselves to present to us in whatever way you want.
Thank you, Chair, and thank you to the committee for inviting BDA to brief the committee today. May I introduce my colleagues Ros McMullen, who is Chair of our BDA Northern Ireland Council and former hospital consultant orthodontist in the Western Trust, and Ciara Gallagher, Chair of our Dental Practice Committee and practice owner representing general dental practitioners, and myself, Tristan Kelso, BDA Northern Ireland Director. Very briefly, if I could set out the scene on the policy direction to date and why direct application of the amended EU regulation on mercury could have such a detrimental impact here. The European Parliament vote earlier this year to ban dental amalgam from 1st of January next year sent shockwaves across the entire dental profession, and no more so than here in Northern Ireland. As our position paper makes clear, we, as in dentists and government, have been working on the basis of a managed phase-down trajectory towards dental amalgam. A phase-down approach is recognised in the Department of Health's Northern Ireland plan to phase down the use of dental amalgam, which was published in 2019, which sits alongside similar national plans for England, Scotland and Wales. And far from being an outlier, phase down is also recognised internationally. At COP5, which is a conference of the parties to the UN Convention on Mercury last November, a proposal to establish 2030 as the phase out date was rejected. A phase down approach was reaffirmed, and that was to respect differences in country capacities, promoting equity and taking an evidence-based approach to identify alternatives to dental amalgam, ultimately safeguarding the oral health of respective populations, and the UK is a signatory to this convention. Phase down of dental amalgam at a rate appropriate for each country is the best and only option for public health, not least considering the immense strain already in dental services. It is also an environmentally responsible approach, which BDA supports. Reducing dental amalgam use requires the necessary supports put in place by governments to manage the move away from this material. And despite having a phase-down plan, we still have a long way to go in achieving the three key strands outlined in our national plan, which are prevention, research on new treatment techniques and materials to replace amalgam, and service delivery reform, specifically GDS contract reform and the development of the community dental service. Being bound under the amended regulation by an arbitrary date of January next year for phase out, when the required preparatory steps, which we are fully supportive of, have not been adequately progressed, is alarming. Deviating away from the established phase down policy, which applies at UK level, and which continues to be advocated by all four chief dental officers, poses considerable risks in the form of irreparable and long-lasting damage to provision of dental services here, not least at a time when health service dentistry is on its knees, and this cannot be overemphasised. As Ciara will expand on later, we have a vital public service which is grossly underfunded, where fees paid to dentists as self-employed independent contractors already bear little correlation with the true cost to provide care, and one example being £10.62 is paid to dentists for a single surface amalgam filling. Yes, dentists are currently being paid £10.62 to place a single surface filling under the NHS. Replacing amalgam for alternative materials will come at considerable additional cost due to much costlier materials and more time required to place, costs which the department should fully mitigate. But based on our recent history, there is little confidence within the profession that this will be the case. Members of the Northern Ireland public are already struggling to access NHS dental care because the service is so poorly remunerated. On financial grounds alone, if directly applied here, this regulation will be the tipping point for health service dentistry. We have shared with you feedback received from dentists about the impacts as they see them should an amalgam ban be imposed. And in the words of one of those dentists, increase in expenses and the ban on amalgam are the perfect storm. I don't know any dentist who will be able to deliver any NHS work next year under the circumstances. NHS dentistry is about to collapse. This is as stark as it gets. And there will be a direct impact on patient care. There are strong clinical arguments why dental amalgam must remain available as one of the tools in the armoury of the dental profession, not least where we have a high needs population. This isn't the case of simply swapping dental amalgam for something else. Dentists are deeply concerned about their high needs patients. They refer to teeth having to be extracted that could otherwise be restored. They speak of being fearful that this will add to existing stress levels on staff, and ultimately increased pressures in general dental services will result in increased referrals into the other dental services, also under immense strain. The amended EU regulation puts a spotlight on the fragile state of NHS dentistry in Northern Ireland, a service that is already rapidly shrinking, with reduced health service activity, which was underspent by £12 million in 22-23 compared with 19-20. An amalgam ban poses a considerable additional risk, which causes many in the profession to be genuinely fearful of its demise. As another of our members put it, failure to mitigate will result in the loss of health service dentistry in Northern Ireland, leaving the vulnerable and less well off in great difficulty. This is a risk that we hope will be nullified through the work of this committee and by the Assembly in agreeing to an inquiry and opposing direct application of the amended regulation. Why are we in Northern Ireland so unprepared for these changes and set to be impacted so severely? The profession would point to a derogation of duty by authorities here to progress real reform and invest properly in modern dental services, in rolling out ambitious oral health prevention measures to improve oral health, in failing to bring forward a new GDS contract that properly and fairly incentivises NHS care, and to invest properly in the dental workforce. The service is so unstable and the conditions have not been met to see a move away from amalgam, certainly not from January of next year, or even within an 18-month time frame envisaged by the derogation, and there are real concerns that the impact this issue could have on the most disadvantaged within our society being able to access dental services. The threat of an amalgam ban may well be the final straw for health service dentistry. Indeed, it may already be too late to avoid collapse of this service. An amendment passed by MEPs referred to Member States endeavouring to ensure appropriate reimbursement being made available to limit the socio-economic impact on costs of care for patients and dentists. Will the UK government pick up the tab? That could easily be in the tens of millions of pounds. In closing, we want to reach a point where amalgam is no longer needed, but we aren't there yet. That requires considerable reform and investment. Combined with the fragile state of health service dentistry, this issue represents a major risk. Above all, there is a collective duty to strive for the outcome that best reflects the needs and oral health profile of our local population. Thank you for listening, my colleagues, and I will be happy to answer any questions. Ciara to lead on general dental services issues and Roz on impacts across dental services and oral health more generally. Thank you.
Okay, thank you very much. And as it happens, I mean, some of these issues, I suppose, are for the wider health part of this, and I am aware that the Health Minister is before the Health Committee this morning, so I'm pretty certain, having had a conversation with my colleague who's the Chair of the Health Committee, that the wider dentistry piece will be raised there, because, I mean, essentially what you're saying, your profession is unprepared for this, and this is the kind of the last act, as it were, in terms of having an impact on the dentist profession. Could I just maybe refer to some of the issues specific to this committee, which I suppose is a specific EU regulation? So there was a compromise text in February, which, if I can read just exactly what it says, so to minimise any negative socio-economic effect, in particular for low-income patients in those member states where phasing out of the use of dental amalgam on January 25 poses considerable difficulties because of the transition in mercury-free alternatives will be not completed by that date, is allowing a derogation until the 30th of June. So, I mean, I suspect NHS patients would fall under that category of patients. So can I maybe ask specifically, because you're labouring on the 2025 date, what difference does this derogation to 2026, what difference will that make in a positive sense?
I'm going to hand over to my colleague Ciara, but I'm going to start that. You're quite right, of course, that the EU regulations have given this option of the derogation. It doesn't come easily. It comes with a lot of work. You have to evidence base that the population will be significantly impacted by such implementation, and it's not just a one-off thing for it and then you can go away for 18 months and start to work on your other plans, but it has to be a continued process, as I understand from reading the regulations. Now, we're all in uncharted waters here, but it appears that it's ongoing work, so that is not something that we should throw out. It's certainly an option, but I'm going to pass over to Ciara, because 18 months in the terms of the three key legs of the stool that underpin the Minamata, which is the UN treaty, are prevention, contract or systems to deliver care, and the third one, research into alternatives. And, you know, all of those are not 18-month projects, they are much longer. But I'm going to hand over to my colleague Ciara.
Yeah, I think whenever the ban was thinking about coming in January, and your question will always be, well, will a derogation do? Will 18 months be enough to stabilise the service? And I think, just elaborating on what Tristan said, I think it's important to understand the backdrop that we're looking at here. You know, in terms of delivery of dentistry to patients, 90% of dentistry is delivered by high street practices like my own, and we are standalone businesses, and like all businesses, we have faced massively increased costs over the last years. But unlike other businesses, we're not in a position to alter our fees to match those costs, because our fees are set by the Department of Health, and no business where you're giving out more than you're taking in can survive, and dentistry is the same. So where we are right now is in a very unstable situation, and that's even without the arrival of the amalgam ban. It's a public service and we need to save it. So in terms of your question about the 18 months, it's going to take time for us to get ready. We need time to develop a proper prevention strategy. There has been work, but we're not there yet, and we won't be there in 18 months. When you introduce a prevention strategy, you have to develop it, you have to roll it out, you have to train people, then it has to go into the population, and then it takes years for those effects to come through, for us to have less tooth decay, and for there actually to be less reliance on fillings, and we're talking about removal of a core filling material. So we haven't got enough time to roll out a proper prevention strategy. In terms of the filling materials, we're not fighting for keeping amalgam forever. We're not fighting for keeping it beyond 10 years. But what we are saying is we're not ready to get rid of it yet because we haven't got a suitable alternative for a lot of cases. So where amalgam really scores very highly is when you have a nervous patient who can't sit for too long for treatment. It scores very highly in patients who have special needs. It is a reasonably economic material, which means for patients from low socioeconomic groups, then it's going to be a good material to look after them. For elderly patients who come in and find it difficult to sit for long periods, amalgam works better than anything else. For patients who gag during treatment, amalgam works better. It is a great workhorse of material in dentistry, and to take it out in 10 months, to take it out in 18 months is going to mean that we will have patients who have teeth that we could otherwise have looked after, and they would have kept those teeth for chewing, they would have been able to keep those teeth for speaking, they wouldn't have to wear dentures, they wouldn't, for children, have to go through general anaesthetics. The ramifications go on, all because we take a core material out of our toolkit as dentists. So a derogation won't do because we won't be ready in 18 months. White fillings take longer to place than amalgam fillings, and just from personal, if I'm placing a large silver amalgam filling, it takes me 3 times as long to place a large white filling. So you're not just saying you will do that instead of that. What you're doing is you're trebling your treatment time. So if you're trebling your treatment time, you're reducing your capacity. You can't see as many patients. So the natural answer to that is have more clinicians, because if it's going to take more time, but it'll take time to train clinicians. Now, we can have dental therapists who can do fillings. They don't do the whole remit of dentistry, but we can have dental therapists. But we don't have a school of dental therapy here. So you're talking, even if we started planning now, we're probably talking about 5 years before the first dental therapist came out to increase the workforce that we would need to take these longer treatment times to treat patients. So that's a real key thing why 18 months isn't long enough as well. Have I answered, is there anything else? Have I answered that
Can I
enough?
ask just in terms of, following on from your question about some of the examples of people and even just in terms of the proposed derogation and who it would encapsulate, what kind of percentage of the community or patients that you treat would fall under that caption that would be included within the derogation?
Well, if I can tell you how many fillings were placed last year in silver amalgam fillings, there's 182,000 amalgam fillings were placed last year. So of those 182,000, if we had to do them in white filling material, then we wouldn't have been able to do it. Percentage of patients I couldn't give you a figure on, but what I can say is if you look across the socioeconomic picture, anybody who's coming from a socioeconomically deprived background will be disproportionately affected by this ban.
And in terms of the difference between a phase down and a phase out, so there was 182,000 patients last year. How many patients were the year before? How many are we dropping off?
I can answer that one, which is we have statistics on how many amalgam fillings we placed back in 2015 and how many we placed last year. So we're down 43%. We're placing 43% less amalgam fillings now than we did in 2015. So we're on our way. Over 7 years, we have reduced the amount of silver amalgam by 43%, but that's over 7 years. So you're talking over 10 months to go from 43% to 0, or even over 18 months to go from 47% to 0. It will break. The service will break in itself, and also patients then ultimately are going to be suffering because clinically they're not going to be able to get the right material to fill their teeth, but also they're not going to be able to access care. So there's 2 problems in that. It will be the complete collapse of the service, so no NHS dentistry for patients, but even if you can get NHS dentistry, a really key material has been pulled out of our toolkit.
Just my final question before, sorry, and you can come in.
Yeah, it's okay. It was gone.
Because it's a ban not just in the use of amalgam, it's also in export and import of it. Can I ask where the dentists in the north, where we get our amalgam? I mean, I presume we don't manufacture it here.
There are manufacturing sites all over Europe at the moment. It's manufactured in China, it's manufactured in North America. And I understand that in Europe, obviously, they're going to be winding down their manufacturing, but we will be able to access it, but it will go up in price. So if this ban comes into place, the routine basic NHS dentistry we do with amalgam fillings will be more expensive anyway. But if you compare the cost of a large silver filling on the NHS and a white filling provided privately, and we would assume that the government would cover the cost, it's 5 times as much in terms of cost. So if you stick with amalgam, your cost will go up. If you get rid of amalgam and you go to white filling material, the cost will be exponentially larger for the Department of Health, who would have to cover those for NHS patients.
Sorry, I thought it was my last question, but you've opened up. Tristan mentioned, and you've alluded to it there, that within this there's an implication that the Westminster would reimburse dentists. Maybe could you just give a full explanation of that?
Yeah, I mean, look, we're obviously in uncharted constitutional territory here, and all we can say is the amendment that was passed, the Commission amendment passed by MEPs, made the assumption that member states would step in. The concern here is, and the question is, will they? But we have to. It's not just getting from a stable situation to offset the risk of amalgam. We need to get to a position where reform should have happened years ago. So is the Westminster government going to step in to bring us from where we are on our knees to that position to stabilise the service and to offset the extra costs from amalgam use? So obviously one part of the member state is covered by this potentially and not other parts of the UK. So those are concerns and questions. If it falls on the Department of Health, we know the 1 billion black hole there, and the concern is they haven't been able to meet the true cost to deliver NHS dentistry as it is. So where's the extra money going to come from? And if they can get only a certain amount, not quite there, it's not going to cut it. So that's the concern. We don't have the answers. Those are big conversations that hopefully you'll be able to take forward.
Thank you. Steve?
Yeah, so this is a couple of questions. Thanks very much indeed for the evidence so far. First one, just for a matter of clarification, why did the EU shift the figure from 2030 towards 2025? What was the rush to shift it on?
Well, this is a very good question. I've back in 2021, the 2030 date was there for phase out. That didn't happen. They did an impact assessment, which was carried out pre-pandemic. So what we would say is the data completely bears no relevance to where dentistry is now than where it used to be. And when we met with the Permanent Secretary in November, there was suggestions that we were looking at a 2027 phase out date, and then suddenly January happened, 2025 shockwave. So we can't answer for the EU. All we can say is the BDA position would be in line with the United Nations, the Minamata Convention, which ruled out a 2030 phase out date and maintained phase down, which has been the policy in place.
Yeah. So just for clarification for your Scottish and Welsh and sort of English colleagues, we're still continuing along the phase down approach.
Yes. And
there is good clinical evidence to support that, as well as the sort of the fiscal evidence and support evidence to do the rest of it. Okay. Do we know what's happened in the Republic of Ireland?
Yeah, so we have very close working relationships with our colleagues in the Republic. They, like ourselves, are part of the CED, so at a European level, dentists are part of that. So it was very much phased down, very much the need for greater prevention in the Republic of Ireland as well. So a common approach to the position that has been in place up to now. So obviously, as they are directly implicated in this one as member states.
They are a lot further on than us in some aspects, in that they have had fluoridation of the water supplies for many decades now.
Yeah.
So, but still in all, they still have a deprivation issue and an oral health issue, and they, I understand, are going to struggle even with a derogation of 18 months, and they are concerned to. They have a completely different system of delivery of dental care, as you probably are aware.
Yeah.
So to some extent, as in all groups, it's the ones who are reliant on their medical cards or the deprivation here in the north, that they are the ones who are going to be impacted the most by such an implementation.
Through your links with the sort of the European sort of dentist movement as well, I mean, I'm aware of some of the research I've done into this, is that there's dentists all over, groups all over Europe are saying, no, we can't do it.
And I worked in Norway for 6 months. And Norway has been ostensibly free of dental amalgam since 2005, 2006. And they have fluoridation to their young population through a schools project, so they get delivered fluoridation. So the decay rate is low, but decay is caused by the diet, and so those who are more prone to decay, the more vulnerable in our society, they still are experiencing decay. And in Norway, unfortunately, the research shows that their extraction rate has gone up. Yeah. So there are more teeth taken out, and I saw that when I worked in Norway.
Because I think sort of the discussions I've had with sort of some of our sort of friends in Europe, particularly in sort of the Baltic states, and then further down sort of Eastern Europe, not so France or whatever it happens to be, but you know, they're all in the same position because they don't know how they're going to deal with when amalgam goes out as well. So that's thank you for that.
One other point is that their dental services are not the house of cards that ours are, because it's funded in a different way and is funded in a better way. So they're starting from a better baseline with a less fragile dental service.
And that's even the same within the UK. So Scotland has developed, you're probably aware, at the back end of last year, a new contract system to which we can talk to if you wish. But and that certainly has gone to, that has gone to stabilise their service. So even within the UK, we are in a very unstable situation. People have described the dental service as being on its knees. I'd say it's further than being on its knees. I think it's on.
Back to the specific issue for this committee, particularly to do with the amalgam. We have this rather bizarre situation, much like people who are trying to sort out construction in their apartments, is that which department does this actually lie in? So this is it might sound bizarre to everybody who's watching this outside, but this is a DERA issue, specifically because it's based around the sort of the mercury thing. I understand DERA have been given the lead to try and sort this out. Have you had any interaction with them, or have they decided to show, push forward, or are they pushing anything through to do this? Because one of the purposes of this committee is to see if this is going to be a detrimental harm to the people of Northern Ireland by any changes that come in and the rest of it. But another role of this committee is to flag up early, so we don't get into the situation where we have to use the storm and break, that here's a problem, we need to get it sorted, and we need to be in communication with the joint working group to do that. That's supposed to be done by the department, but has DERA engaged in any of this?
Look, I think to date, DEFRA was the lead agency on behalf of the UK. The 4 chief dental officers were very much, including our own chief dental officer here, sort of led on a lot of that work from an impact on dentistry clinical. No, we have had no conversations or contact yet from DERA to this point. I think the sense is that January's vote caught people in unprepared.
My final question, Chair. If we look at the phase down, and is dentistry in the UK ready for the phase down towards 2030, or is that still a sort of aspirational to an aspect of that?
2030, we are at a standing start. But 2030 would be more achievable than 2025. I think still it's a very tight date, 2030, considering that if you had good targeted prevention, and we have an obesity strategy which is finished consultation, we have oral health improvement strategies which are in consultation, so the work is being done to start on that. But even if you started targeted prevention yesterday, the child being born today is going to be 5 in 5 years' time. So you're not going to see that starting to push through until that sort of length of time lag. So I think 2030, considering we're now in 2024, time seems to move so fast. That's only 6 years away. I think
just to sort of paraphrase this, because the question we have to ask is, this is going to have a detrimental effect on the people of Northern Ireland by this derogation. Can we have a one-word answer, yes or no?
Yes,
absolutely.
Thank you very much. Okay, Chair, thank you.
Saoirse?
Thank you, Chair. Sorry.
Well,
Apologies. Can you hear me okay? Yeah.
Yep.
Yeah.
Okay.
Yep. Apologies, I can't be there in person today. I'm not very well, but I just wanted to touch base with you guys and BDA, and thank you so much for coming and giving evidence today. I think it was Tristan and also Rawls had said that we're in uncharted territory, and clearly we are. But what we want to make sure that we do as a committee is do our job fully. It feels to me that this has come almost at a perfect storm. And I know we're very keen to remain within the tramlines of the responsibilities of our committee, but nonetheless, I think it's impossible to have a conversation on this without the wider impact where NHS dentistry is at currently. And you all very much have my sympathy and support, because clearly much more support is needed. I just wanted to ask very briefly, in terms of the conversations with potentially DOH. I know Steve has made a reference there to DARA. Clearly there's a very niche role in terms of chemicals and regs around that. But I am concerned that no matter what we do here, there is going to be an onus to increase the sort of training needs that we require going forward for the future, because clearly no matter what, we will be using more of the new white filling, and clearly that involves more training places. So I was just wondering what the conversations have been to date in that regard.
Yes, again, I'll start maybe and then pass over to my colleague, Saoirse. Thank you very much. You're quite right, training is very much highlighted as one of the needs, and not just of the dentist, as Ciara has pointed out. It doesn't have to be necessarily the dentist placing the fillings. We have therapists who can do that, but also the nurses handling the material. And that requires a specialist training. So even those within the workspace at the moment will need trained, as well as increasing the workplace. So I think there's two strands to training. We have a brilliant training agency in Nimdata who provide training to the profession, and certainly those conversations have been had of the need of that. And I think I can't speak for them. Obviously, as part of your inquiry, I'm sure you'll look to them. But I'm quite sure that they are very well aware and anxious about the training needs that would be required to fulfil the requirements. So training is very much part of the conversation that we have had, and it's one important strand that would need to be taken into consideration and takes time.
I think if I could just briefly add, Saoirse, so a key part of the national plan was to grow and develop the community dental services, and we've had a workforce review that was done in 2018 and only just been published. And that said, even pre-pandemic, it said because of the growing ageing population, that service needed to grow from a headcount of 80 up to 117. The headcount has actually been reducing down over recent years. So instead of growing that service, and we have, again, like all of these things, we understand the difficulties financially, but that service, that growth needs to happen in order to be able to sort of meet, the obligations here under that we're faced with. The GDS probably that deals with 90% of the care. It's about trying to retain and not lose practitioners to do NHS dentistry, and that exodus is very much, it's well underway already. So that's, in terms of the growth, it needs to happen. We've been pushing for workforce planning, but we really aren't moving forward very quickly at all.
Saoirse, you happy?
Thank you, Chair. I just had one last one. In terms of the finances of this, there had been a discussion briefly at the start where, if I have picked this up correctly and read the briefing, where in the situation of the rundown, there was almost an expectation that part of that would be covering some of the financial outlay for the for basically the cost of procuring the white fillings, because there will be more of a price differential. And that, did I pick you up rightly whenever you said that there had been an expectation, maybe not across other devolved regions, but in mainland Europe, that there had been a period of crossover where the purchase and the procurement of the white fillings and associated costs had been partially subsidised for a period of time?
I'll let Ciara answer some of that, but of course there are different methods of providing and funding dental care throughout Europe. So we have a fully funded NHS system which provides comprehensive care to the majority of our population. That is not the case for most other countries in Europe. So it's a different situation for a dentist providing the care in France, possibly under either an insurance plan or on a pay-as-you-go private basis, that could be subsidised to help that transition. So that's a different system and a different way of thinking than we would have in the UK. Certainly the need to, and I think Ciara has very clearly outlined, and she will again, I'm sure, about the difference in cost. She does it day and daily of providing white fillings over the silver amalgam filling, both in time and costs of materials, and taking into account that, like any medicament, so any producer of dental amalgam has to go through a licensing process to license their product. That takes money and time, and that investment may not happen from certain companies. They may decide to withdraw from the market as the market shrinks in size. So there'll be less competition and more cost to amalgam. But I think Ciara pointed that out, and maybe Ciara wants to expand upon the costs.
Well, as I said at the beginning, just where we are is that what is being paid to dentistry doesn't cover the costs of care. So there is an inaccuracy at the moment of covering what we're doing. So there is a huge lack of faith amongst the profession that the government will actually accurately calculate the new costs of these materials. And that's why in our latest survey last week, that if this ban came into place, it's almost 90% of dentists said that they would intend to leave the NHS, because there's a miscalculation at the moment, and that's why the service is on its knees. And what's to say there won't be a miscalculation in the future? We know what it costs to run our businesses, and we know that the NHS fees don't cover it. So why would new NHS fees for a more expensive material and a more costly procedure, why would they be any different? They will not cover those, and it will be more of a loss to provide NHS dentistry. So it's back to stabilising the service. And I think because the service is so underfunded, we're really struggling. NHS committed practices are really struggling to recruit dentists. There are multi-surgery practices in deprived areas that only have one dentist working in them to serve thousands and thousands of patients because they can't recruit. And the reason that they can't recruit is the dentist going in there, and all the statistics show that a committed NHS dentist in Northern Ireland is the lowest paid dentist in the UK. Now, it's not all about money, but it's about survival of the service, and the service won't survive as it is. And if this ban comes in, there's absolutely no chance that anybody who's limping on will, and as I said, 90% have said if this comes in, they will leave. So that's no care. And, if we go back to the thing, significant impact to everyday life of the communities in Northern Ireland, and you can't get to see a dentist.
Yeah, and I would point the committee to number 21, 22 and 23 in the position paper, just outlining the extent of dental decay in Northern Ireland. It is a non-communicable disease and very similar in its epidemiology to other non-communicable diseases that I'm sure you have heard about. We have, and those, I'm not going to go through those figures, you can read them, but we have high levels of decay. We have 3 times the rate of extractions of under a general anaesthetic for our children, pro rata. And we do know, we have the figures there, the statistics that shows that it impacts on the areas of deprivation. So, on every tick there, we have a really important core population that needs dental treatment, that I am speaking for today, that they continue to get that care that they so need, whether that be a white filling, a silver filling, whatever the dentist feels is right with the conversation with either the child, the parent or the patient. And that is something that happens within the dental clinic. But that we protect that. Sorry, I get a bit passionate about it. I apologise.
If I can just come in very briefly there as well, you know, we're talking about significant impact. If people can't get to see the dentist, there's a knock-on effect on all the other services. So you have people with toothaches and swollen faces coming into A&E. You've got GPs who are already, you know, coming down with treatment requirements. We have patients who can't get screened for cancer, and therefore by the time they present they will be later stage and they will have worse survival rates. We will have hospital general anaesthetic services for children who will have more decay. They will be overwhelmed, and the specialist oral surgery services. So when you take out a tooth, the more damage the tooth is, the harder it is to take out. So those specialist services will be overwhelmed. So there will be a ripple effect right through the whole community through other services that will be taken up by dentistry, where we could have actually kept it within our building and not had it to the ramifications through the whole of healthcare.
And if I could speak up for orthodontics very briefly, being the orthodontist that I am, when you have a crowded mouth, quite often you try and avoid taking teeth out these days, but sometimes you've no option but to take out teeth. It is much easier for the orthodontist and much easier for the patient, and the treatment is shorter if the right tooth is taken out, not the tooth because it's is decayed and rotten and the dentist is telling us it, so it's no life. So certainly from the point of view of orthodontic treatment, it will improve the care of the child.
And not being the harsh chair, I think everybody here, certainly from a constituency MLA point of view, because we deal with constituents all the time who are struggling to see dentists, so we're all aware of the crisis within the dentists. But I do just want to keep everything, if we can, focused on the issue of the amalgam and the impact on that. Or we'll be having a conversation that's
certainly
very
the orthodontic
good,
issue
really
is the amalgam issue.
Absolutely.
It will be the wrong tooth.
Absolutely. Saoirse, you're finished? Can I ask then Jonathan?
Thank you, Chair, and can the committee hear me?
Yep.
Thanks very much to the British Dental Association for the presentation this morning. I think you've made a very good job at simplifying something which sometimes can come across as very complex. The real life impact to citizens across Northern Ireland is very, very clear, and you can hear that sense of panic even in your voices and in terms of your correspondence as to the impact that it would have. You've been very clear with the committee, which I suppose probably was not the perceived way in which the committee would have felt that they would have been had concerns brought to them, in relation to the fact being that you believe that the Stormont Break should it be applied now, or the processes relating to the Stormont Break, such as the launch of an inquiry. Can I ask what your experience to date has been in terms of registering the concerns of dentists in Northern Ireland as to the impact that this proposed EU law would have on Northern Ireland?
Yeah, well, I guess first and foremost, this is the committee that has the responsibility to hear those concerns of any amended EU regulation or any new act. So in terms of our focus, it's very much we respect and we value that there are democratic structures here and this committee to do that job. So I suppose all we have done is we've engaged with yourselves. We've obviously engaged with the Health Minister as well, just to lay out the concerns of the profession and the impacts, and we've met with officials and shared our briefing paper along those lines, and I know we have another meeting with the Minister scheduled as well. So in terms of engagement, we've been watching very carefully at a European level through our membership of the CED, the Council of European Dentists, and we're also part of an international group as well. So obviously Stormont's only come back, and this is the early stages, but I guess timing is the issue. This regulation, the vote happened before Stormont came back. Stormont is back now, and to be quite frank, we sighed a breath of relief that Stormont is back, that these Windsor Framework institutions are here to potentially, look at things. Obviously we come at it from a dental perspective, from a dental public health, and you will be looking at these things from a wider round, but we just want to be as clear as possible about impact and hopefully to inform that job. So that's where we're at. It's quite early days obviously, but we expect that this regulation amendment could be before us very, very quickly.
We did meet with the department 2 weeks ago and did share the same position paper and the concerns that we have. So we have met with them.
No, I appreciate that, and I can sense the frustration probably that something's coming down the tracks very, very quick. I suppose the committee's role is to look into whether or not this will have a detrimental impact. And following on from Steve's initial comments, and maybe Ciara can point to this, in terms of the real life impact for citizens in Northern Ireland in terms of service provision, if this proposed change to EU law did apply to Northern Ireland, how quickly would you anticipate a breakdown in service provision?
Almost immediately that the decision was made, then dental practices, business owners will have to go back and rewrite their entire business plan for the year based on a whole new model of treatment delivery, and that under the NHS cannot happen. When you put it into your spreadsheet, you will end up with a seriously negative number at the bottom. So as soon as that decision became law within our country, and that was where we were in January, then there would be an immediate rewriting. The statistics show from last week is 90% of dentists said that they would either reduce, or 50% said they would completely leave. So it's a collapse, and it's an immediate collapse.
The EU has claimed that the manufacturing and import can continue in limited circumstances, such as specific medical needs. Is this pie in the sky thinking? Is that possible? It's already been answered where the dental amalgam actually comes from, but will the supply from GB to Northern Ireland be fettered by additional certification if it can only enter Northern Ireland for very strict medical purposes?
I'm going to jump in for 2 seconds on the medical purposes because they haven't been defined, and I think until we had a definition of how broad that we could use our dental amalgam, because I've listed at the beginning lots of people in the population that would be affected by not being able to have amalgam, but that has not been defined in terms of specific medical needs. So that would be something that we want some clarity. But Tristan,
look, as this committee, I know we strayed a bit into other health arenas and so on, but, obviously, in terms of the BDA as a UK-wide organisation, BDA Northern Ireland, clearly we see the massive extra risk from this regulation, but even in GB, our colleagues are extremely concerned about the indirect impact on cost of supply, on access to supply, all of those issues. So regardless, it looks like the whole of the UK will be impacted about this, whether there's, obviously there's potential for extra impact. So that's the sort of conversations that we're having.
Okay.
And how acute is an issue, for example, of tooth decay in relation to deprived areas in Northern Ireland when it's compared across the United Kingdom? And not to get too much into the debate around, lack of service provision or difficulties facing the industry, but I'm just trying to get a picture of how the material impact on deprived areas in Northern Ireland when you compare it across the UK.
We know our so we know that dental decay is like any non-communicable disease is impacted within areas of deprivation. So there are surveys that are done on a regular basis throughout the United Kingdom, and they're done generally on 5-year-old, 12-year-old, and adults, and they happen at various intervals. And without going into the details or of a lot of figures, but we consistently come out as the highest decay. The region is suffering not only the number of the population who are experiencing decay, but within the population that is experiencing decay, it is worse. So there's more teeth decayed, missing, or filled within the group which have increased decay. If that answers your question. It is a disease of deprivation, and it is a disease that impacts upon a group at a higher level.
Just to add on, in 1920, so the last full financial year before COVID impacted, there were 21,000 GA extractions carried out in children, and that's roughly 3 times pro rata higher per head than in England. So that gives you a sense of the oral health, the links with deprivation and how we're at the bottom of the league table UK-wide on this one. Oral health improvement plans, the consultation is only closed to update our 2007 oral health strategy. So we've had a vacuum there. there's been a lot of good work done by the Chief Dental Officer, but that obviously needs to feed through. So 3 times worse off per head.
And
than
again,
England.
I just want to reiterate that figure, 21,000 teeth. And that's the end of the spectrum. That's general anaesthetic extraction. That's not talking about the extractions carried out in dental surgeries under local anaesthetic or under sedation, carried out by the community service under sedation. So that is the end of the spectrum. And you know the population of children in Northern Ireland, 21,000 teeth extracted under general anaesthetic. So that is not a statistic that we're particularly proud of.
I know you asked about
Okay.
our health in relation to England. Just within Northern Ireland, when you compare children from deprived areas to other areas, they are 3 times more likely also within our country to have tooth decay. 3 times more likely if you're from a deprived area.
Those are startling statistics, and can I thank you very much for answering your questions very, very directly. I want to say just very firmly that I share your concerns, and I thank the BDA for bringing that forward to the committee today. Thank you.
Thanks, Jonathan. Joanne?
Thank you, Chair. Could I ask quickly, have any other member states of the EU signed up to the Minamata Treaty?
I think there's, from memory, we can get you the information, but there's something like 140, 150 countries are signed up, to Minamata. So we can get you that information after the meeting.
Thank you. So just so that I can be clear and my takeaways are correct from your evidence, you have indicated that in your briefing paper and orally, there's no evidence that mercury from amalgam fillings has any harmful effects on health, that the inequalities that currently exist in terms of deprived and non-deprived will be significantly exacerbated. This is me trying to establish significant impact that will persist. You've indicated that we are nowhere near ready. You have said that, the disparity between the deprivation and not, and the statistics around that are fairly stark and shocking, to be honest. And that is the number one reason for hospitalisation of children, which is extraction, yes. Mm-hmm. And at this point, faced with the choice, then people will extract teeth rather than fill. And that also I noticed in the evidence that people will extract teeth because of fear of litigation. Yes. So far, these are all accurate, significant impacts. I note that the cost differential, an amalgam filling £8.13 to £20.90. And then with a white filling, that increases to between £80 and £150 per filling. A stark difference. And you've indicated that business decisions are being made now. So by the time all of this works its way through, it could be too late to essentially save NHS dentistry. So far, so good.
So far, so
good.
Right, that's fine.
There is a solution, and there's a quick solution, but it's for another committee, which is the Scottish model. Stop talking.
That's fair enough. The issue for us, I suppose, the issue that I'm trying to understand is, have I got the significant impact for Northern Ireland down, just so that we've got it too. So let me see, in terms of, you're saying also the derogation is going to have a significant impact on the most disadvantaged in our society. You remain unclear. The EU may well say that member states should reimburse appropriately, but we remain unclear at this juncture whether or not that will happen on the basis that current levels of service are not being adequately funded. Yes? Okay. Philip already dealt with one of my questions with regard to the impact of the derogation. So let me work through this. You have also, so the impact that I read in your dossier, that the health impacts of replacements for amalgam have not yet been fully tested.
I think there's further research to be done. I mean, one of the big areas that has been raised is the potential of microplastics. We are signed up to getting to a point where we don't need mercury or amalgam fillings anymore, but we don't want to be in a rush job to displace one environmental issue with another. So the research hasn't been completed yet, and as far as sort of a suitable alternative material that does everything that mercury does, that hasn't been found yet.
So essentially at some stage at this point, the EU appears to have jumped the gun considerably.
Yes.
Okay. And you've indicated that essentially treatment time will treble and costs will double. So in circumstances in Northern Ireland where there are already significant impacts to cost of living, and dentistry is already having an impact in terms of people's costs, and when faced with the choice of day-to-day essentials versus oral health care, people are choosing day-to-day essentials, so this is going to make them continue to make that choice. What is the likelihood of the EU, I suppose, moving into, maybe you're not in a position to answer this and it could be speculation purely, but from past experience of what you've seen, what are the chances of the EU moving if its member states kind of indicate, look, we can't make this deadline, it's not practical, because presumably we're not the only ones in financial difficulty over this. So what's...
Look, I think, we're a small player in a very big game here. I think the way we have seen this is that we need to, put the panic button out there to yourselves, and that's the role of these institutions and this committee in particular, I think, to take those issues up. We are in no position to have direct conversations with any European officials. There's no Commission office anymore in Belfast. There's no MEPs to appeal to, but there's an important democratic role for this committee to do what needs to be done for the population locally. So that's our appeal really, and that's why we're here.
Joanne, if I can just go back briefly on the treatment costs doubling, I think that's an underestimate because it's based on current underfunding. And there's, in certain situations, you can put white fillings and back teeth and they're grossly underfunded. They're the worst funded treatments that we provide. So the figures that we worked on, we wanted to work on real life figures, which were the figures printed, but I have to sort of say that treatment cost doubling, it is not a real world figure. It's much, much more than that. Just to put that on record. We based it on inadequate fees, and therefore the treatment cost, because we have to come in line, we have to recalibrate all the fees, and recalibrating those treatment fees that have been used in the sums will result in a significantly higher cost of non-amalgam alternatives. Just wanted to...
That's really helpful, Claire. Thank you, Chair. Just one more question. So am I right in asking, presumably research does show that there's a direct correlation between poor oral health and poor health generally?
Yes.
And that one exacerbates the other?
Yes. There's quite a lot of research going on at the moment, and has done in the past, about the interrelationships even within the epidemiology of diseases. Yeah. So we have a lot of evidence around gum disease, and we've focused a lot on decay, but obviously the other thing that dentists see a lot of is gum disease, where your gums around and the bones around your teeth, and there's a lot of relationship between that and heart disease. So we are learning more about the epidemiology of non-communicable diseases, disease processes that not have been particularly well researched, and when they have, they're sort of researched in silos, and everybody's sort of finding the same thing, but now people are coming together and seeing those interrelationships.
So essentially then, when people are making the choice between a dentist service that's going to cost at least twice what it currently does, versus having to feed their children or heat their homes, they're not going to choose oral care, which again speaks to significant impact that will persist. And lastly, there's something within your briefing paper, I think, is there something that indicates that were we to diverge from the rest of the UK, at that point it becomes difficult for practicing dentists here to move to work elsewhere within the UK, is that right?
Yeah.
Because you're trained across the whole spectrum of materials, and therefore if you're not trained within one aspect of it, it's harder to move into a different jurisdiction.
And that may actually lead to a loss of our undergraduate trainees in whatever, whether it's therapy or dentistry. That could lead to a reason that people move, and move outside the UK as well, because remember, places like Australia, Canada are all still on a phase down trajectory.
It strikes me, Chair, and with this I'll close, it strikes me that the case for significant impact that will persist has been more than adequately made by this evidence, and I consider that, bearing in mind the financial position that the bulk of people in Northern Ireland find themselves in at this point, to not take action on this would be a real dereliction of duty on the part of this Assembly. If we care about our constituents and their socio-economic position and the choices that they will have to make in these circumstances, then the long-lasting impact of this could be horrendous. I don't think any of us want to see National Health Service dentists crash and burn, and that to be lost to our society. Thank you.
Thank you very much.
Declan?
Thanks, Philip, and thanks very much for coming in this morning. And I know that it has gone outside the scope of the committee, but nevertheless, the various observations and insights that you've been providing have been very helpful. I mean, what you have mapped out in quite stark terms for me is what I would describe as the medical pathology of poverty and deprivation. And this particular region, as you well know, as professionals, is a region which presents with the highest mental health and well-being, or the worst mental health and well-being indices. With higher levels of child poverty. We're a low-wage regional economy, and we have areas in the north which have not reduced their indices of poverty and disadvantage in 25 years. They remain persistently and tractably high. So when then you relate all of those factors together, of course, it's very, very apparent then how issues around oral hygiene, oral health care impact directly on other morbidities, or indeed they become consequential to other morbidities. I think Ciara made the point very well. So what we're dealing with here is a perfect storm of cross-cutting issues, which is why I think it's also useful that Steve brought into focus the fact that there is a DERA issue here. There is a very, very significant Department of Health issue here, which is outside the remit of this committee, but you are already engaged there. And then we are dealing as a society, I believe, with in multiple ways the consequences of the Brexit decision in 2016, and it never ceases to seize my opinion or my perspective that in so many different ways these are not just economic issues; they have consequences that impact in social and health, cultural and educational terms. So, in many ways, we're dealing with a big legacy here, and I think it's notable that the British government, in its negotiation around preparing for the exit from the EU, and then in anticipation of trying to manage the mitigations arising from that, have not identified this particular issue as one of the points on the horizon. But we are where we are. So to come back then on the points, we have a backdrop here of a health service which is already deeply damaged in endemic difficulties right across the entire spectrum. And your own particular profession within the health service, I have always considered to be, if I can use the term, one of the Cinderella elements of the system. And I actually relate dental care and oral hygiene and the work that yourselves do as professionals to the challenges we have in relation to oncology, cancer research, the challenges in relation to adult learning disabilities, and the extent to which so many of those particular aspects of health and well-being are underfunded, underinvested, and resulting in vast pressures that have real-world consequences for us in broader society. So, I have a couple of questions, and I would like to come back at the end briefly to a point which Steve raised. I don't want to rehearse the ground that he did with the 26 counties, but I would be interested in getting some insight from yourselves on the extent to which your own association have spoken with colleagues in the South about levels and states of preparation for this, given that the 26 counties remains a member state. But if I can put this question to the three of you, first of all, is our dental profession and the provision of oral and dental health care in crisis?
Yes.
Thank you.
Rightly.
And would you agree that of very stark implications, but nevertheless consequential to the chronic underinvestment and instability of dental services in the North?
I think if you had a steady dental service that was funded properly, where dentists had faith in the planning that was going on for NHS dentistry, I think that we probably could handle this a little bit better. It's not to say that amalgam is such a useful material, and I think it has a very important place, but this would not be such a significant blow if our services were more stable. I'll go back to the house of cards analogy, and this is it. Whereas if you had a solid house and you had this on top of it, well, you could absorb the strain somewhere else.
I think you described that very well earlier, Ciara, as did Ross. But what we are dealing with here is a real world consequence of a context, and therefore what we are dealing with has to be seen and understood in context and in perspective with an historic and a current situation which has presented profound challenges and systemic crisis for our broader health and our broader health and social care.
And I think you put it very well when you put in context of, and I worked in Derry, when you put it in context of the position we are with the oral health of our population at the present time, and the work that we all need to do as a society to improve that. It's not necessarily the fault of the people themselves. It's how the system that we put for them. It's getting them access to care. It's getting them access to healthy choices. These people are in economic strife at the moment, as you and I well know. They are making difficult choices, and this is not to. It's really important not to blame society, the patient. It's what we provide and the process and the systems we provide to have the care, so that children do miss out less school because they've got sore teeth, because people can go to work because they're not taking their child for a general anaesthetic to have a tooth out, so that the non-verbal child, and there's great work goes on in the community service. I can commend that to helping, and again we're straying and maybe beyond this, but it's important, the context, the great work that the community service to provide care. But if patients are being displaced into the community service because of of this issue, this particular issue with amalgam, that's only going to impact secondarily on those patients that are receiving that really good care in the community service.
So the point that I want to approach a conclusion on, my penultimate point, is the detrimental effect, therefore, to society is not in and of itself deriving or directly from this particular issue. The detrimental effect for society in the North is within the broader context of underfunding, underinvestment, and inadequate planning, preparing,
policy,
and policy relating to oral hygiene provision and dental health care services in the North.
Yes.
So thank you for clarifying that. And then my last point briefly just relates to the issue of the South and the extent to which the Committee of European Dentists, yes, has the committee conducted an assessment of the phasing out of amalgam in whatever time frame, and its repercussions for the 26 counties, as well as you have done for here? And do we have a sense of the multiplier effects that will be challenged by your colleagues, your counterparts in the 26 counties, as well as England, Scotland and Wales?
I can talk to aspects of that, and certainly, ahead of this meeting, we're regularly in conversations with the Irish Dental Association, and what I would say is, as part of that CED, the Council of European Dentists, their position is very aligned with ourselves, and it's been like this. We're being bounced from a managed phase down approach into something, an acceleration of the phase out timetable to just next year. So I know there's conversations, and we haven't talked about the patient exemptions, which is another part of this, and I'm sure Europe would talk to that it's not just amalgam can't be used and that's it, but those are conversations that had to be had at a member state level. So I know that's probably the space that the IDA would be in there, but not speaking for them, or this isn't just at a European level, at an international level, at FDI, the International Federation of Dentists, phase down is the direction that we as the profession need to maintain. That we're already making a certain level of progress. We need to maintain that trajectory, and we're being bounced into something different. So I don't see a lot of prevention in the Republic of Ireland as well as something that again with ourselves. If you prevent, if you improve oral health outcomes, you reduce the demand and the need for these filling materials. So that work should have been done. We've felt like a lone voice over many, many years, actually championing on behalf of NHS dentistry, and a bit like the cancer strategy before it. The excuses and the delay and the reasons why we can't do these things, instead of going ahead and actually identifying what is in our gift to change and to prepare and to look at the return on investment. You spend £1 now, you achieve so much down the line. So we're here in a really poor position because that work hadn't been done, but we're not on our own either. There's others. Yeah.
Thank you, Tristan. Thanks.
Thank you, Declan. David? Broadcast, bring David in, please.
I think, sure, it's my fault. I'm having a is that it now?
Yes, we can see and hear you.
Yep. Thank you very much, Chair. I think a lot of the issues have been dealt with comprehensively by both the presentation that you've given, so thank you for that, but also the questioning from colleagues, and it's clear to me from the outset, indeed it was probably before we got to the committee today, but certainly it's been given added emphasis that action is needed urgently on this, and it's something that demands our attention and demands that we take we use all of the tools open to us in order to give protection to the dental sector in this regard. So a lot of the questions have already dealt with the issue comprehensively. So mine probably a little more technical, and it just goes back to, I know Steve touched on it, but this interface of departments and who's responsible for what. We understand that DERA will be and DEFRA in terms of the UK will be responsible for the will be the lead on it in terms of mercury and the chemical side of things. Do we have a clear picture of who would be responsible for defining the medical exemptions provided for in the proposed act? And is it appropriate for dentists to be put in a position where they're having to decide what's strictly necessary, quote unquote, in terms of medical exemptions from the use of the amalgam?
I'm not saying we have a clear picture at this stage. We don't have a clear picture of any of this, to be quite frank. But in terms of exemptions, our understanding of the EU reg, the amended reg, is that be done at a member state level, but within certain, it's unclear as to how confined or how free that will be. The changes that were made, the original regulation give a wide berth for clinical discretion to determine the medical needs and the types of patients and the exemptions. What we're unclear about, and I know at European Parliament level there were some, issues over the wording of that. So what that would look like, I presume in a Northern Ireland context, it would be the Chief Dental Officer would have input into that, but it's unclear, has she got a free hand there, or will there be constraints to for her even to work within? We're not sure about that yet.
And I think it would be tricky at a clinical level as well, because if you have a set of criteria that say the patient doesn't match and the patient is sitting in your chair and you know that dental amalgam is going to work better than anything else, but they don't fall into the category, where do you sit as a health professional? Are you in breach because you didn't match these regulations, or did you act in the best interests of your patients? So it adds a real level of confusion, concern and stress when treating a patient.
Yeah, no, absolutely, and I think that's probably what I was pointing to in terms of, I think it's a very difficult position for our dentists to be put in, to try and decide what is strictly necessary and what is not in relation to this legislation. And who then? And again, it may be something that you yourselves can't answer. Maybe a question for if the clerk has any input in this. But who's responsible for articulating the case for delaying the implementation of the amalgam ban to the Commission, given under the proposed act that your justification would have to be given? Where does that fall in terms of departments? Does it fall because of the lead in terms of the chemical side of things with DAERA, or is it with health in terms of them explaining the medical issues with it?
I mean, look, I in terms of the derogation, my reading was that obviously it's the impact, and then there seems to be a bit of confusion about at what point can those high-level conversations be had between at a UK EU member state level. Does the storm and break, does the inquiry have to be held? If and when then does the storm and break need to be applied, and then do those high-level conversations need to be had thereafter? I'm sure the relevant departments would be feeding into that process, is my reading on it. I think DAERA would have a role in enforcement, and there's another angle, in terms of policing this and what that would look like. So big high-level conversations, and I suppose we look to this committee and the Assembly and beyond to take those issues forward on behalf of the sector here.
Thanks, and and I agree. We all, as we did the last meeting, are working out where the parameters are in terms of what action we can take when is the most appropriate action to take it. I think we're doing the right thing by essentially going through an investigation process, even if not formally, but and yourselves here today being the starting point for that. But certainly, I think my colleagues have expressed this pretty much already, that whenever it's appropriate to take those actions in terms of the process, I think this is a very clear case for those levers being pulled, and I think that's my position, and I suspect it's the position of my colleagues as well. Thank you very much, Chair.
Thanks, David. Patrick?
Thank you, Chair, and thank you all for your presentation. I think it's important we're doing this piece of work at this stage, in the early stages of the committee, and obviously we're still all getting an understanding of exactly the remit, and I think someone referred to the tracks of the committee and staying within those rails. And quite a few of the points I was going to make have been taken. I think Joanne referenced the whether there was any sort of wiggle room remaining in the legislative side in the European Parliament, and whether that was a done deal. Now, reading the documents in front of us, particularly given the vote in January, it would maybe suggest that was, but I don't think we've totally ironed that out, as you've rightly identified, and I think it would be important for this committee to get a final opinion on that, and whether there is likely to be any changes there in terms of the period of the derogation or anything like that could buy us a little bit more time. Declan made some important comments about working within the context of this place. Ultimately, it is the remit of this committee to decide and judge on the potential impact of these new rules on life in Northern Ireland, and I suppose we can judge a a good or bad law on the prima facie evidence, but we have to work within the context of this place ultimately. It can still be a good law with a bad impact if we are not ready to absorb the changes that legislation lays out. But at the same time, the context here may well change. And that's where any submissions that we get from the Department of Health are going to be incredibly crucial here. There is a chance that this is a spark that lights a bit of change in the department to respond to the pressures and the crises within your industry. And I think that this committee can play a valuable role in getting a clear idea of what the Minister of Health's plans are for the dental industry in Northern Ireland to enable it to cope with this. And I think if that response comes back to say that he has minimal plans, then that is going to be a very serious consideration for this committee. But we ultimately, I don't think, can make a decision until we know the plans that the Minister has to address these issues within his own department. Obviously, there will be an important submission from DERA there as well in terms of the top line regulation and enforcement of the use of the materials. But I think ultimately the only thing that is going to change the context in which this legislation applies is decisions within the Department of Health. So I think it's really important at this stage, Chair, that as a committee we are pushing both departments, but particularly Department of Health, for a submission of evidence to see how they are going to respond to this legislation. And am I thinking that we can do that now if we haven't already?
We can have a discussion about what we do afterwards once
Okay, no problem.
once we finish the session. So you have no specific questions, Patrick?
I think most of them were
Fair
asked, to be honest. I'm sorry, Phil.
No, you're grand. So I mean, that was very, very thorough, very, very informative. So we do thank you very much for coming before us and presenting, taking the questions. And I mean, it's clear we're all very sympathetic, as pointed out. And I mean, this committee will do its job in terms of the specific issues in front of us as well. So thank you very much.
Thank you very much.
Can I propose, just given that we did go beyond this committee's remit, that a copy of Hansard be sent to both Department of Agriculture, Environment and Rural Affairs, Department of Health, and both committees, just in terms of some of the issues that were raised, if people are content?
Sorry, Chair. Apologies. I'm sorry, you first mentioned that. Chair, maybe also the TEO as well, because remember we've had briefings from the TEO Secretariat as the relationship with the Joint Consultative Working Group, who's probably the organisation we need to contact next to start working this problem through.
Okay, I mean, I'm open to.
We had the briefings on the alphabet soup, but I think it's important that this is an important issue, and we probably need to strike that.
Yep. I'm not sure that this specific issue, I mean, I'm happy for members, but I mean, the issues that were raised today are clearly specific to the Department of Health and the Department for Agriculture, Environment and Rural Affairs. In terms of notifications and comment on what we do beyond that, we would always filter that work through the Executive Office. Yeah. But I'm just thinking of the Hansard, those issues this morning are for those two departments. But I mean,
just because we had quite extensive briefings from the Executive Office and trying to build that relationship with their interrelationship with the various committees. So I think it's important that as a matter of principle we do that, because we should be asking them for all their stuff that they're getting as well. So
okay, I'll be enough for that. So just following on then from that, so at last week's meeting, members will remember we agreed to write to the Department of Health and DERA just requesting information on this Act. So some of the information we requested doesn't specifically address the areas that we as a committee must have regard to when deciding to conduct an inquiry, and I'm always conscious that we have not been notified when I'm talking here, but if members are content in anticipation of a published Act being notified to the committee in the near future, the agreed templates which cover the areas that we've discussed and that which we must have regard to, we could send those to those two departments and legal services and the executive office for completion in advance of any notification if people are content.
Agreed.
Okay.
Chairman, just before we move off this, can I ask a couple of questions that I'm not clear around? There's stuff in that document that relates to lamps. There's stuff that relates to monitoring crematoria for mercury, and there's also stuff about tire balances and wheel weights. Can we, whenever we're in the middle of all this, can we also get information about the impact of that?
I mean, I think the department will have a duty.
Well,
they will have a duty to respond to the impact of the EU legislation in its totality. So, I mean, they will cover the whole legislation, even though we're very clear there's a specific issue at stake. But they should, and when they're responding, look at the whole legislation and the amendment.
Yeah, it's just been they were proactive.
Yeah.
But some of these things, I mean, that stuff about tire balancers and wheel weights could be an issue, I think.
Another one would be lighthouses as well, often on mercury beds.
Yeah.
I have a local issue on that.
Just gonna ask the
MOT
clerk.
centres,
Just as a reminder, the templates that will go out will ask specifically about whether it appears likely that the Act in its entirety, as the Chair has said, would have
Or elements of it?
Yeah.
Okay.
And TEO will coordinate a response from all the departments that it's relevant to, so you should get that sort of composite response back.
So what we will do is we will send the request through the executive office. They then filter that to, in this case, essentially DERA and DOH, and then that will come back to us.
Just for clarification, maybe the clerk can help us with this one. Part of the process, and I remember discussing this with the EU, is that if we have identified something that it's likely to create a problem later on, we should be using our good offices to be able to contact through the joint consultative working group and through the various committees, so that we're highlighting it as well. Should we also be using, because it's very clear that I'm not putting words into anybody's mouth, but I think we've had a very clear indication that this would be a significant derogation or a significant deviation and would have a major impact in Northern Ireland. So therefore it would become in the various other committees. But having identified this problem already, should we not be sort of escalating this, or at least writing as a committee to say, here's an issue that we have? Because the process has been designed so that we never get to the point where we have to pull the brake, because we've already sort of done the initial consultation. I think we've got a very clear indication here that it's a problem. So should we be my recommendation to the committee would be we should be writing to the joint committee.
I think, Steve, we shouldn't jump the gun. There are two criteria this committee need to fulfil before it, and just in the thoroughness of this committee doing its job, let's wait and see until we speak to everybody that we need to speak to and get all the opinions and advice that we need to speak to before making a decision. I think that would be the remit and responsibility of any committee with regard to any action, and I certainly think that's what we should be doing. We should follow our processes, gather all the information, see that the criteria that we need to meet is met, and then judge what we do in the aftermath of that.
Just share one final point. One of the conversations I've had with various members of the EU is the fact that there's a scanning ahead approach, and they've asked us specifically if we see something that they should be aware of, and much as there's been an indication that they will do the same thing through the sort of Northern Ireland Executive Office and the rest of it in Brussels, they would come back to us. We've clearly seen something here that they should start be thinking about it while we're gathering the evidence, because between now and the 1st of January is a very short time in sort of legislative and bureaucratic terms. So I just want to emphasise that, and I want to put that on the record, because I have now formally asked this committee to consider us getting in communication with a joint consultative working group to highlight to them we think this is going to be a problem. But it's up to the committee to decide whether they agree to that or not.
Chair, just on the basis of what Steve has said, like the issue is what we were hearing from the officials last week from TEO was that early engagement is key.
Yeah.
So on that basis, I mean, I think from what we've heard today, it seems to me the threshold for concerns of this committee have been met, to be honest. I mean, that there is significant impact for the people of Northern Ireland that is likely to persist. So I think whatever action we can take, we can we should take at the earliest possible opportunity, because that doesn't preclude us still gathering further information. You know,
I mean, just to be clear, there are 2 criteria that this committee need to meet. So, you know, we haven't even got information back from the second aspect of that. So I'm just cautioning people. Absolutely. So, Declan?
Yeah, I think we're straying very quickly into the territory here of preemptive moves. And I'm picking it up from both the spoken and the implied remarks of other members. So let's do this the way it's meant to be done. And evidently, in terms of horizon scanning, and I touched on this in my own remarks, that's a matter for the TEO and the NI Bureau to be raising directly with the European Commission. It's not for us at this point in time to be writing off to the joint committee. So let's follow the procedures and the structures that are already in place. And the question was put to the evidence presenters: are we already in a crisis situation? And we are. And we've been in crisis prior to receipt of this presentation today. In terms of detrimental effects on society, the detrimental effect on society, and I'm taking it that it will have been written accurately into Hansard, has already been recorded. There is already detrimental impact on society arising from the chronic underinvestment and the sustainability of dental services in the north. This adds an additional complication to that. But let's get this into perspective, keep it in context, and most important of all, follow the correct procedures, and let's not preempt or jump the gun to take us into a position which I think would become much more problematic down the road.
I mean, and I think just for completeness of the discussion on this, I don't think anybody in the EU isn't aware that this is an issue for here, Britain and other member states, because it's we're having a very specific discussion about here, but we have heard that this isn't just solely an issue for here. So I mean, I don't think that this isn't an issue that's on the radar of the EU, and I suspect that's why the derogation was made in February. But as I say, there's a proposal from myself that we continue the work that we kind of agreed that we would do.
I made a recommendation. I would like to propose that we write to the Joint Consultative Working Group. Okay. And I would like that, not recorded, but I would like to
absolutely. I'm going to make my proposal. I will allow your proposal, and then we can allow the committee. So my proposal is that we do what we agreed we would do last week, that we, in terms of gathering evidence, do what we did today, that we have already written to both departments that we'll follow that up today and write through the Executive Office for them to complete the agreed templates of this committee and also legal services, so that we are in a better position to make any decision or judgment thereafter when we have that information. Your proposal, Steve?
Jonathan wants to come in.
Yeah, Chair, could I just second Steve's proposal in relation to writing to the Joint Committee? I think it would be a dereliction of duty that we don't flag this up. Again, this is merely raising the concerns that the committee has been presented with today. Very clearly, members have concerns right across the political perspective. So I don't understand why the committee would fear flagging this issue with the Joint Committee, given our role and responsibilities as a committee. So I'm happy to second Steve's proposal.
I mean, just in terms of, I think there's one proposal, we can vote on the first one, which is mine, and then depending on that, we can. I don't think there's a fear, Jonathan. I think, my concern is we haven't done all the work that we would be writing to any committee on the basis of not having completed the job that we are tasked to do. So my proposal is that we complete the task, gather all the information, be in a better position to do the job that this committee is mandated to do. So it's not a fear of anything. It's actually ensuring that the committee fulfills its duty to the fullest.
Yeah.
Chairman,
I respect that, Chair, because there is procedures, I understand. But I suppose probably the point that I would raise is that I don't think that any member doesn't have concerns of what they've just heard. So to present that to the Joint Committee in a form of writing, I don't see what the problem would be in relation to that.
Chairman, can I just ask, not in terms of procedures, but in terms of principle, are the proposals mutually exclusive? Is there anything that prevents us from flagging up, look, we're worried about this, we do believe it meets one half of the test, but we're continuing to gather evidence with regard to the legal aspect? I mean, is there anything that stops us from doing that? Is there any reason why we shouldn't do that?
And there's no reason. I mean, I at the risk of repeating myself, I, as the chair of this committee, I can't speak for other members, I haven't got all the information that I feel I need to have a full picture. I mean, we haven't heard back from the Department of Health with regard to this, for a start. We haven't heard back from the Department of Agriculture and Rural Affairs, for a second. And thirdly, we haven't heard back from legal. So I don't know what I would be writing, or this committee would be writing to anybody about, or why we would be doing that until we gather all the information and have all the knowledge. I mean, the two departments and legal opinion are crucial to any of the work that we need to do. So
Sorry.
I'm going to push for a vote. If people want to push.
Can I just come in, Chair? I had actually had my hand up before Johnny, and like that's grand, but I just wanted to come in. I mean, I understand people's anxiousness around this, and we want to be doing the right things when people raise them. Is there a middle way that we can? I mean, I'm happy to support whatever, but is there a middle way that we can actually write to the UK government, possibly, or whoever is relevant there, and ask what conversations has gone on between them and the EU or whatever? Because ultimately, we're not going to be able to have those conversations. And I'm just aware that the BDA had said, look, there is no EU office in the north, so we're relying on you to flag these points. And I think you're absolutely right. We do need to copy the Hansard of today to DOH and DERA. But I'm just also aware that they were explicit in their sort of expectation on us. And again, I don't think that would be in any sort of preemptive way. I think that would be completely without prejudice. So that may be a middle path.
Chair, if I could just, I think we're almost undermining the credibility of the committee and the process that has been set out if we're jumping the gun and deciding off our own bat to write about things without having first heard all of the evidence that we need. This is already in the public domain. These concerns have been raised, so I don't think anyone is under any illusion that people aren't aware of this problem. A derogation has already been proposed. So I'm sort of reluctant for us to stray into that territory where we're writing off letters and flagging things up before we've even followed our process, which, as you've all outlined, we haven't. So I think that needs to remain the focus of this committee, to follow the rule as set out.
And I mean, I'm also conscious that we're meeting two Westminster scrutiny committees next week. I have no difficulty or no doubt that this is an issue that could be raised. We're going around circles. I'm going to put my initial proposal to the meeting. Chair or Clerk, can I just ask, is it show of hands?
Show of hands.
Okay, so just for no doubt or no question of doubt, the first proposal, which was mine as chair, is that we follow up what we've already wrote to the two departments on with engaging with the Executive Office so that they will come back after engagement with Department of Health and Department of Agricultural Rural Affairs and the legal services with the templates completed as in advance of any decision made. So that's the proposal that I would ask members to vote for. Those in favour, show your hands.
Sorry.
So, Chair, just clarity in that's to rule out writing at this stage. So I'm just going back to the point that Joanne made about sort of we can walk and chew gum at the same time. We can continue our process, but there's in terms of writing a letter to flag this early. Are you saying that voting for your proposal here rules out then Steve's proposal thereafter?
Well, in my opinion, my proposal is that we gather the information before we write to anybody. So essentially, it is ruling that out.
Okay.
No, we can't support it then.
Okay, so just take that vote again. Those in favour? Can we check anybody on the screen? No? Okay. Those against?
Sorry, can I just David, Jonathan. I'm missing one here, and Steve. Sorry. So what about Saoirse?
So
I voted for.
For. Okay. Okay. So the question was that we follow the agreed processes and continue the evidence gathering exercise. For, we have Philip McGuigan, Patrick Brown, Saoirse Eastwood, Declan Kearney, Emma Sheeran, and against we have David Brooks, Steve Aiken, Jonathan Buckley, and Joanne Bunting. So the motion is carried.
okay, thank you. So the motion is
And
carried.
will we now hear Steve's promotion?
Not if it was ruled out for the first proposal, surely, Chair.
Yeah. It wasn't. I mean, it wasn't. According to the clerk, it wasn't ruled out, so we can take a vote on that.
I formally propose that in line with our commitment for early engagement, that we also write to the Joint Consultative Working Group, which is the interrelationship between the EU and the EUK on this significant issue that we have already heard evidence on and are still gathering evidence further.
Those in favour?
I'm happy to second that proposal.
In favour.
Those against? We'll just check those online. Anybody against? Raise their hand.
Okay. So I'm assuming Saoirse was for then? Saoirse?
Yeah.
Yeah. Okay, so for we have David Brooks. Sorry, I should read the question first. Given this committee's commitment to early engagement, right to the joint consultative working group in this significant issue and continue our evidence gathering exercise. For David Brooks, Steve Aiken, Jonathan Buckley, Joanne Bunting, Saoirse Eastwood. Against we have Philip McGuigan, Declan Kearney, and Emma Sheeran.
Sorry, Ray, did you read my name out there?
Sorry, Patrick.
No,
I
you
didn't see
didn't
your
read
hand.
Patty. You
Were
didn't
you?
read
Yeah,
Patty
I was
out.
for Steve proposal.
Or okay, so the motion's carried.
Okay, so we'll write
Well,
to.
that's I didn't think we had to vote on it.
Okay, so that proposal is carried as well. Within both.
Interpretation of standing orders would have said.
Invite members to ask questions.
Wi-Fi plans?
Okay, moving on then to item number 5, correspondence. So at item 5, response from Professor David Fenimore at Queen's University. It's page 81 of the pack, and that's a response to our request for examples of association agreements between the EU and European states, where comparisons could be drawn with the North and lessons could be learned. Are members content that a copy of the response is forwarded to the Committee of the Executive Office for information?
Yes, I'm content.
Okay, 5.2 issues. A response from the Chief Executive of the Assembly, and that's at page 88 of your pack, to the Committee's request for information on the resources that will be made available to support the work of the Committee. The response states that the Treasury was notified of a budget requirement for 13 posts at various grades. At the development of tracking system, committee travel and miscellaneous costs. So this funding has not yet been allocated to the Assembly and is not included in the updated 24-25 budget requirement that was submitted to the Assembly's Audit Committee. So a further update will be provided once Treasury has confirmed the position. Members will wish to note the Treasury did indicate its intention to allocate proportionate funding to the Assembly Commission for 23-24, but the Commission advised that the funding wasn't necessary as there was available budget within its existing allocation. So are members content to note for now and wait a further update?
Can I ask a question on that?
Yes.
So on the basis that the Commission declined money, is that going to cause us detriment further down the line?
Clerk, if you want to come in on that.
I imagine that's a matter of interpretation, Joanne.
I mean, we're waiting for a response, so some of that might be contained within that.
I think it bearing in mind all that we've heard is there are issues about resources and capacity that the Commission may well have put us in a situation there.
We
Going
can write to
forward.
them if you're happy, just to ask.
I think we maybe should, because if they're taking that now, so everything's fine, and well, they didn't need the money, they had plenty, that could cause us problems and cause problems for the departments on down the line.
Yep. Okay, I'll have to write from the committee. So, next item is chairperson business, of which there is none. Number 8 then, so just to inform members that the next meeting of the committee has been...
Number 7, we're not doing AOB?
Oh, sorry, Steve. Any other business?
Yes, Mr. Chairman, please. I'm sort of, regardless of, and regard to the rest of the committee's views and various views, I've raised this issue with the committee before about the geographic indication protection, which was tabled on the 21st of Feb, and I believe the Cabinet Office wrote to us, but it shouldn't have gone to us, and it went to everybody else in the back of it. It hasn't been scrutinised, it hasn't been tabled, and the timeline to be introduced by the FM and DFM has been exceeded, and the timeline to be introduced by any member on the floor of the Assembly expires on the 19th of March. And I'm aware from the Business Committee none of it's been tabled. So this is as we're aware, this has to be voted for on the floor of the Assembly. It's not, as you have determined, Chair, it's not within the boundaries of this committee, but indeed it is an applicability motion which may have significant effect, but we don't know because nobody's looked at it or scrutinised or anybody's looked at it. I just wonder, and I probably know what the answer is going to be anyhow, but I just wonder if the committee should write to the TEO and to the Speaker asking what's happened to this particular piece of legislation, because it's an applicability motion that probably comes within the wider remit of the scrutiny of sort of European legislation that's likely to come to us, and it seems to have disappeared under the ether and nobody's taken any notice of it whatsoever.
I mean, we can ask we can certainly ask what the position is. You've outlined the position. I mean, there's a deadline there that
which is passed for.
So, I mean, we did what we were supposed to do in terms of we weren't supposed to do anything, but the information came our way and we forwarded it on to the Executive Office. But I mean, we can certainly write.
It's just I mean, if this was the first piece of applicability motions or EU legislation we're supposed to deal with, we haven't done very well with it, have we? No, I'm not referring to this committee, I'm just saying generally this is just something that's sort of trundling along and nobody's got any input into it at all.
And I mean, I should just remind people, because there'll be people listening, there was an option for any MLA to signal a debate. So, but no, we've agreed now that we will write seeking an update.
Thank you.
Okay, apologies. Any other member, any other business? No. Date, time of next meeting. So, members, next meeting of the committee has been scheduled for next Thursday, 21st of March, 2024 at 10:45 in room 30. However, as we agreed earlier, we're going to meet here at 10 a.m. For a private Zoom meeting with House of Lords. So, are members content that given the public holiday next Monday for St Patrick's Day, meeting packs are issued on Tuesday of next week? Okay.
Yep.
During the meeting,
okay.
Can I just ask the committee secretariat to close the meeting, please?
And then there's something after the meeting next week as well.